Good morning, everyone. So today we have a lecture on choledochal cyst to be presented by my senior colleague, Major General Dr. R.P. Choubey. Dr. Choubey received his training in GI surgery with Professor Samiran Nandi at the All India Institute of Medical Sciences. And after serving for a long time in the armed forces, he then served as the director of the institute in Andaman. And then he joined our department as a professor, and he's currently the emeritus professor of surgical gastroenterology. So Dr. Choubey will discuss with us today about choledochal cyst.
Good morning, Professor Kapoor and dear students. Thank you for a nice introduction. The topic of my talk, as told by Professor Kapoor, is choledochal cyst, and I shall be covering my talk under the following heads: introduction, classification of the cyst, etiopathogenesis, clinical presentation, investigations, treatment, post-operative complications, and finally, I will summarize. Choledochal cysts are the congenital anomaly of the bile ducts defined as abnormal, disproportionate cystic dilatation of bile ducts. Their incidence ranges from as low as 1 in 1 lakh to 1 lakh, 1 in 1,50,000 in the Western world to 1 in 1,000 in Asian countries. Then Japan has the highest reported incidence. It's more common in female. They are 3 to 4 times higher as compared to the male. Frequently diagnosed, this problem is frequently diagnosed in infancy and childhood. Almost in 80% of the cases, it is diagnosed in infancy and childhood, while only 20% of the cases are reported in adults. Water and Esler were the first to publish the anatomy of choledochal cyst way back in 1723. This disease is associated with high incidence of biliary cancer, and the incidence ranges from 10 to 30%. However, CDC constitutes only 1% of all benign biliary disease. There have been of site, extent, and the shape of the cyst. Term bile duct or biliary cyst is semantically more appropriate than choledochal cyst, as the dilatation can occur anywhere in the biliary ducts and not confined to the choledochus only. Hence, hereafter, I shall be referring choledochal cyst during my talk as biliary duct cyst. First, systematic classification of bile duct cysts was proposed by Alonso Leys and his colleagues in 1959, and he only classified the extrahepatic biliary cyst. And the type 1 cyst is cystic or fusiform dilatation of the extrahepatic biliary ducts. Type 2 is the diverticulum of extrahepatic biliary duct. Type 3 is the cystic dilatation of limited to intra-duodenal portion of the lower end of the CVD. it did not include intrahepatic cyst. However, it formed the basis of all other subsequent classifications. Size of the cystic dilatation has not been defined thus far either by its absolute size or the ratio of measured to expected bile duct size at the cyst site in the biliary tree. Subsequent recognition of the intrahepatic biliary cyst prompted the modification of this Alonso-Layer's classification, and Todani first in 1977 modified the Alonso-Layer's classification by including the intrahepatic cyst. Type 4 cysts were multiple cystic dilatation of the extra and intrahepatic bile ducts, while type 5 cysts were only multiple cystic dilatation of the intrahepatic bile ducts, which was described by Caroli and colleagues in 1958. Intrahepatic cysts are sometimes associated with intrahepatic fibrosis, and this combination is known as Grumbeck's disease. Most of the types of biliary duct cysts are further subdivided. The secular or fusiform dilatation of the extrahepatic biliary duct is further classified into type 1A and type 1B based on the site of cystic duct attachment. As shown in the figure, type 1A is where the cystic duct is attached to the biliary duct cyst. In 1B, only distal CB is cystic and the cystic duct is attached to the normal extrahepatic biliary duct. And 1C is the smooth fusiform dilatation of the extrahepatic biliary cyst with anomalous pancreaticobiliary duct junction. Type 2 is a cyst supraduodenal diverticulum of these either the CHD or CBD. Type 3 is a diverticulum of the intra-duodenal CBD, referred as Choledochocele as well. And type 4 is dilatation of both extra and intrahepatic biliary ducts, which are further subclassified into dilatation 4A, dilatation of the extra and intrahepatic biliary ducts, and 4B is multiple dilatation of the extrahepatic duct only, and there is no intrahepatic involvement, giving it a shape of a string of beads appearance. And type 5, though initially it was only the intrahepatic biliary cyst of any shape without the extrahepatic involvement, but now it's broadly applied to describe the intrahepatic biliary cyst, irrespective of the presence of extrahepatic biliary cyst and the shape of the intrahepatic biliary cyst.
I'll just quickly run through the slides so that the students can see what Dr. Choubey talked about, and then we will continue. हाँ हाँ नहीं मैं ये अच्छा उधर तो पूरा दिख रहा है ठीक है ओके ओके And students, please, you should feel free to interrupt if there is any problem. The transmission. Yeah, sometimes we don't look at the chat, so please feel free to put your mic on and say what is wrong.
Now we can see the slides.
Yes, yes.
Matsumoto modified the Alonso's classification based on the configuration of cysts in addition to their location. However, the clinical presentation or the surgery of biliary duct cysts are dictated by their location and not the configuration. Hence, consequently, also there was no rationale for adoption of Matsumoto classification, and it was subsequently abandoned. Type 3 cyst or the choledochocele, most of them are incidentally detected on ERCP being done for some other problem. As told earlier, they are not associated with anomalous pancreatico-biliary ductal junction, and their most common presenting symptom is pancreatitis. Biliary symptoms, which are the commonest presentation of biliary duct cysts, are unusual in choledochocele. Terumi, Kamisawa et al. Further classified choledochoceles into three groups. 3A was the cystic dilatation of the common channel. 3B was the cystic dilatation of intramural bile duct forming the common channel, and cystic 3C was cystic dilatation of the intramural bile duct opening into the duodenum separate from the pancreatic duct. This classification is useful for the analysis of the pathogenesis and determination of therapeutic strategy. Type 3A and B cyst may lead to two-way regurgitation, inducing acute pancreatitis and higher incidence of biliary malignancy. Saris et al. Further classified choledochocele into 4 subgroups with therapeutic implications. Type A was the CBD and MPD terminate into a choledochocele, which drain directly into the duodenal lumen through an aperture into the cyst wall separate from the papilla. The type A is further divided into 3 groups. A1 is present, this choledochocele is present into the intraluminal portion of the duodenum with common channel opening into choledochocele. A2 is again choledochocele is present intraluminally with separate CBD and MPD opening into the cyst, and A3 is the cyst is intramural, and type B cyst is choledochocele protruding intraluminally but draining into the portion of the common channel and then in the intramural portion and then into the duodenal lumen through a normal papilla. This is the diagrammatic representation of all those types classified by Saris et al., where you can see in type A1, the cyst is intraluminal with the common channel opening into the cyst and then the cyst opening through an aperture into the duodenal lumen. In type A2, the CBD and MPD are opening through the 2 different openings into the seal, and then it is choledochocele is opening into the lumen through a separate aperture. And type A3, they are choledochocele is intramural with a common channel opening into the cyst. And in type B, there is a intraluminal projection of the cyst with a common channel, and then it is opening of this cyst is into the common channel, and then that is opening through a normal papilla. The types of type 2, type 3 diametric representation of various types of biliary duct cysts. With the advent of and findings of some other rare types of cyst, anatomical variations in the cyst, further addition to Todani's classification has been proposed. Type 1C I have already described. It's a fusiform dilatation of the entire extra bile duct. And type 1D is the dilatation of the complete cystic duct in addition to the type 1C, and that gives the cyst a bicornal appearance. I apologize for the spelling mistake. It is CORNAL, not U. And then type 6 is an isolated dilatation of cystic duct only without any involvement of either CHD or CBD. This is a very rare anomaly. And then the type 7, it's an extrahepatic bile duct duplication, and this is extremely rare. Coming to the etiopathogenesis of the biliary duct cyst, multiple theories have been given. Anomalous pancreatico-biliary ductal junction is the most widely accepted theory. However, this presence of an anomalous pancreatico-biliary ductal junction is not associated with all types of cysts. They are only associated with type 1 and 4 and not with type 2, 3 and 5. APDJ is a pancreatico-biliary ductal junction is proximal to the sphincter of Oddi. It is extraduodenal. It is a long common channel more than 1 centimeter proximal to the ampulla, and this anomaly predisposes to the pancreatic juice reflux into the biliary tree, leading to inflammation, ectasia, and dilatation of biliary ducts. This theory of anomalous pancreatico-biliary ductal junction is supported by manometric studies, the high concentration of pancreatic enzymes in the cystic fluid, and the histopathology of the cyst, which comprises of ductal epithelial hyperplasia, round cell infiltration, and marked ductal fibrosis. Other theories are hereditary, as the cysts have been found in many members of the same family, though it's a rare occurrence. Then oligoganglionisis has been reported in the most terminal part of the CBD or in the distal neck of the bile duct cyst. This is akin to the biliary equivalent of Hirschsprung disease. However, its isolated presence without anomalous pancreatico-biliary ductal junction leading to biliary duct cyst is unknown. Abnormal function and spasm of sphincter of Odai induces regurgitation of pancreatic juice into the biliary tree. This evidence suggests there is some anatomical and functional obstruction of the distal CBD with raised intra-ductal pressure, and that is probably the most likely cause of biliary duct cyst. Then other theories proposed are defect in the ethylization and recanalization of developing bile ducts, and there is a congenital weakness of the ductal wall, which too has been implicated. Although much more common in females, these bile duct cysts, sex hormone and congenital intrauterine endocrine disturbances have not been implicated as a possible cause of biliary duct cysts. Coming to the clinical presentation, the presentation is often vague and non-specific. Patients may remain asymptomatic for years, and the diagnosis of some of these cysts may be incidental. Presentation may mimic calculus biliary tract disease, and the presentation differs substantially in infancy and childhood and the adults. Some authors consider biliary duct cysts in children and adults as two different entities. In adults, there has been an increased rate of associated hepatobiliary pathologies like pancreatitis, cholangitis, and biliary malignancy. Classical triad of pain, right upper quadrant of the abdomen, jaundice, and mass in the right upper quadrant of the abdomen are the characteristic findings of infancy and childhood. In contrast, in adults, the most common presenting symptoms are chronic abdominal pain, recurrent cholangitis, pancreatitis, biliary lithiasis. Weight loss is a sinister presentation, as 70% of such patients have associated bile duct malignancy. Rarely, biliary cyst in adult present with features of cystolithiasis. Most frequent, this is the most frequent accompaniment, and stones are mostly soft and pigmented. Then hepatolithiasis, and this is mostly seen in type 4 cyst due to stasis or migration from the cyst. Calculus cholecystitis, pancreatitis, cholangitis, intrahepatic abscesses, intraperitoneal rupture, bleeding due to erosion into adjacent vessels, secondary biliary cirrhosis, and portal hypertension is associated in 15% of the patients with type 1 and 4 cyst. In addition, patients with type 3 cyst may present with gastric outward obstruction due to large intraluminal cysts. Coming to the investigations, laboratory studies, there are no lab tests which are diagnostic of bile duct cyst. It's the radiology or the imaging, which is the mainstay of diagnostic armamentarium, and this includes transabdominal ultrasound, CT scan, CT cholangiography, endoscopic ultrasound, intra-ductal ultrasound, direct cholangiography, ERCP or PTC, and then the MRCP. Coming to the transabdominal ultrasound, this is the first modality to be used in for the evaluation of bile duct cyst. However, sensitivity varies from 70 to 90%. type, but this investigation being non-invasive and easily accessible and available. First, it is used as a first modality. Type 1 cysts show an irregular, at times show an irregular hypoechoic segmental dilatation of the extrahepatic bile duct. Focal thickening or nodality of the cyst wall may suggest malignancy. Their ultrasound is a good modality for detecting intracystic stones. Absence of septations inside the cystic cyst distinguishes the biliary cyst from the extrahepatic biliary tumor like cyst adenoma. However, it has a poor yield in type 3 cyst for the obvious reason because of the small size and duodenal gas. In Caroli's disease, multiple cyst of segmental, there is a multiple cyst of segmental and sectoral intrahepatic biliary ducts. However, communication between the cyst and intrahepatic biliary ducts cannot be well delineated, and for that, one needs biliary scintigraphy to delineate that communication. As expected, the usual limitations of ultrasound apply. Coming to this CT scan, this can detect all types of biliary duct cysts. And what is most important is that in addition, mostly in adults, it can evaluate various associated lesions, if any. It's also useful for the determination of extent of intrahepatic cysts in type 4A and 5 cysts. CT cholangiography. Here the IV or oral cholangiography is added with the CT scan. It's highly sensitive, however, has a low sensitivity for the evaluation of main pancreatic duct. So it's not a very good investigation for, particularly for choledochocele. Or oral contrast, you can give 6 grams of hyaluronic acid tablets 6 to 8 hours before the CT scan, and in IV cholangiography, you give IV injection 2 to 3 hours before the CT angiography. Endoscopic ultrasound. US can detect extrahepatic cyst and better discern the choledochocele, better delineation of the cyst wall and pancreatico-biliary junction, and it does not have a limitation or the limitations of trans-abdominal ultrasound. However, it is limited by the poor availability and the expertise. Intra-ductal ultrasound has been used for early detection of malignant changes in the cyst, and is more sensitive than direct cholangiography for detection of malignant transformation in the cyst wall. Hepato-Biliary Scintigraphy, it only provides the functional result and not the anatomical information. Hence, it is only an complementary to the ultrasound, CT or MRCP. And as I have told earlier, it is usually used for delineating the communication between the cyst and the biliary ducts. It's also used for detection of cyst rupture. Cholangiography, historically, it was the mainstay of the diagnosis of biliary duct cyst. and biliary duct cyst classification was based on cholangiographic findings. Now it is mostly used as an adjunct to non-invasive cholangiography, can identify anomalous pancreatico-biliary duct junction and the filling defects due to stones or malignancy. Delineation of pancreatico-biliary ductal junction is a must to avoid damage to the pancreatic duct during excision. It is of paramount importance when you are dealing with the choledochocele or any type of cyst. It has increased risk of cholangitis and pancreatitis. Moreover, patients with choledochocele duct cysts are at the higher risk of above complications. ERCP and PTC, this delineates the anomalous pancreatico-biliary ductal junction very well. It's also used for better assessment of associated malignancy by biopsy or breast cytology. It's good for intercystic stone management, and one can also now do the spyglass cholangioscopy. PTC is usually is for the evolution of post-hepatic geniostomy stricture and the type 4A strictures. MRCP, that's a gold standard for imaging of bile duct and pancreatic duct, and its sensitivity ranges from 75 to 100%. It does not have the risk of post-procedure cholangitis or pancreatitis. It has good ability to diagnose anomalous pancreatico-biliary ductal junction. However, limitations are it is non-therapeutic and it's less sensitive in diagnosis of choledochocele. Coming to the treatment, biliary duct cyst is primarily a surgical disease. Surgery is the mainstay of treatment of majority of the biliary duct cysts. Earlier, almost half of the patients were treated with partial cyst excision and cystoenterostomy. However, in view of the increased rate of anastomotic stricture and higher rate of malignancy in the residual cyst, surgery of choice these days is complete, and also with the improvement in techniques, surgical techniques, surgery of choice is the complete excision of the cyst, extrahepatic, followed by Roux-en-Y hepatico-jejunostomy, mucosa to mucosa anastomosis, or in children, one can resort to hepatico-duodenostomy. However, a word of caution, this in patients in childhood who have undergone hepatico-duodenostomy, it has been subsequently seen the incidence of biliary malignancy is higher in such patients. Aims of preoperative evaluation are complete definition of the biliary duct cyst and the associated pathology. Patients with ascending cholangitis need appropriate antibiotics and the drainage by ERCP or PTC. Surgery being the only definitive mode of treatment, as I told you earlier, it is decided based on the type of the cyst and associated pathology. I am just giving an outline of the surgery. Details of surgery we can talk in some operative session. In type 1 and 4 cyst, it's the excision of complete extrahepatic cyst down to the level of communication of the CBD along to the pancreatic duct, along with the polycystectomy and Roux-en-Y hepatogenostomy is the surgery of choice, as told earlier. However, in children, hepatoduodenostomy is usually performed, and its an advantage of hepatoduodenostomy is anastomosis is accessible to endoscopic subsequently. In certain difficult cases, one has to leave behind the posterior cyst wall with thorough mucosectomy of the left behind cyst. In type 4B cyst, the intrahepatic cyst may necessitate appropriate hepatectomy. Type 2, 3, and 5 cyst. Type 2 cyst is just an excision of the diverticulum and repair of bile duct. It seldom requires hepatogenostomy. Even if there is a bigger rent that can be repaired on a T-tube. Type 3 cyst, now surgery has been totally replaced by the endoscopic management, and it can be managed by an endoscopic hysterectomy and the deroofing only, or sometime endoscopic excision can be resorted to. Type 5 cyst may, in Curly disease, may require appropriate hepatectomy, and some of them may even need liver transplant. External drainage of the cyst has no role in the treatment of biliary cyst these days. Long-term follow-up is necessary for the detection of anastomotic stricture and age-related malignancies, as it has been reported in even those patients who have undergone complete excision of extrahepatic cysts. Other surgical procedures in patients with recurrent acute pancreatitis and unresectable cyst due to dense adhesions, intracystic closure of the base of the cyst proximal to its junction with the pancreatic duct, and concurrent transduodenal sphincteroplasty is advocated to prevent further episodes of pancreatitis. Lilly et al. Devised the same procedure which I had talked, that serosal surface of the cyst, where it is badly adherent to the portal vein, can be left behind, and the cyst mucosa is obliterated by the cautery or curettage, removing the risk of malignant transformation of the remaining cyst. Post-operative complications include cholangitis, biliary stone formation, anastomotic stricture, residual debris in the intrahepatic biliary ducts, intrahepatic bile duct dilatation, malignancy, though their incidence decreases after complete excision, though not completely animated as told earlier. And this decrease in incidence is probably most likely due to complete diversion of the pancreatic juice, which is carcinogenic, decreases the production of secondary bile acid due to the reduction in bacterial overgrowth as the obstruction has been relieved, and the abnormal cyst epithelium has been excised. To summarize, friends, biliary duct cyst is a congenital disease, mainly of infancy and childhood, while in 80% of the cases it is diagnosed in infancy and childhood. Only in 20% of the adults it is detected. Associated problems are more common in adults. The presentation is vague and sometimes they are incidentally detected. Imaging is the mainstay of diagnostic armamentarium. It's primarily a surgical disease. Complete excision of the extrahepatic biliary duct cyst ruined by hepaticogynostomy is has the best outcomes. Intrahepatic biliary cysts often necessitate appropriate hepatectomy. Laparoscopic approach is fast, replacing the open approach. Endoscopic management is now the standard of care for type 3 cyst, management of type 3 cyst. A malignancy in residual cyst and even completely excised cyst is the most dreaded complication in BSD, in biliary duct cyst. Thank you.
Thank you very much, Dr. Choubey, for a very elaborate coverage of the topic. Students, since there is a very high possibility that you may either get a case of choledochal cyst in the exam, or it may come up during the discussion of a patient with jaundice. So a few points which Dr. Choubey has very beautifully highlighted, but for the sake of repetition of their importance. So one is the nomenclature. So some examiners may now use the term, the new term, biliary duct cyst. So be aware of it and don't think that it is something else. So whenever you have recurrent cholangitis in a young patient, it has to come in your differential diagnosis. That's a very important point which Dr. Choubey mentioned. Of course, stone disease is commonest, but when you see a young patient with recurrent cholangitis over a long period of time, you should think and talk of choledochal cyst. Also, keep it in mind as a cause of recurrent acute pancreatitis. All the classifications are important, not from practical exam, but from theory exam point of view. And the important point he highlighted that the association with the anomalous pancreatico-biliary ductal junction is more frequent, more associated with type 1 and type 4 rather than the other types. And there is a school of thought which thinks that the other types probably are a different disease and 1 and 4 are different disease. So that point you have to keep in mind. He very beautifully highlighted the indications of various investigations. For example, endoscopic intervention is mainly to control cholangitis. CT is when you suspect malignancy. Intra-ductal ultrasound and cholangioscopy, if you have them available, is for early detection of malignancy. Isotope scintigraphy, mainly to think of rupture, which is one of the uncommon complications of choledochal cyst, especially in children. And percutaneous intervention, mainly in the follow-up to diagnose or more to manage a recurrent stricture. And this point also comes frequently in discussion about the risk of malignancy in choledochal cyst. So there are two hypotheses. One is that the risk is because of the reflux of the pancreatic juice into the biliary tree. That is handled if once you disconnect the systems, and that should decrease or take away the risk. On the other hand, the other hypothesis is that the entire biliary epithelium, whether it is dilated or not, is carcinogenic. So in that case, excision will not completely take away the risk, with the point which Dr. Choubey highlighted. I don't think we know the answer, but you should be able to discuss it on those points. And that hypothesis is the basis of various surgical procedures. So these are the few points which I thought. Dr. Saraswat also is here. Maybe he would like to make some comments.
Good morning, Dr. Kapoor and I think it was a very elaborate and a very educative presentation today. A lot of new things or a lot of details we came to know. General Choubey, my major concern and the major dilemma we often face is the differentiation between biliary tract obstruction vis-a-vis choledochal cyst. Now, in any biliary tract obstruction, particularly stone disease, meriscese, impacted stones, and so on, which are extremely common conditions, you get dilatation. Quite often, this dilatation is confined to the extrahepatic biliary tree because it is a low-grade, long-standing obstruction and not extending into the intrahepatic tree.